In this video, I want to give a warning about the potential risk of long-term continuous use of B-cell depleting medications in multiple sclerosis. These are drugs that take away B lymphocytes, the white blood cells that make antibodies, such as Rituximab, Ocrevus, Kesimpta, and Briumvi. Now, these medications have been around for a long time. Rituximab has been used for other autoimmune diseases such as rheumatoid arthritis, but in those diseases, often the drug is given temporarily, maybe for a few years, and then the drug is stopped when the patient is stabilized. But in multiple sclerosis, because the potential risk of stopping the drug is permanent injury to the central nervous system, there's unfortunately a tendency to need and use these drugs for a long time, even years and decades. And in my opinion, the risk of taking these drugs long-term continuously is quite significant. Now, when we study these drugs, the clinical trials are typically 2 years, and they look relatively safe with most people not getting serious infections. Also, there's a tendency for people who enter clinical trials to be younger and healthier on average than the typical person with multiple sclerosis, who may be somewhat older and may have more medical comorbidities and may be at higher risk of getting infections. Now, I'm going to give a little review of immunology, the relevant immunology, and I'll be fairly simplistic and not too technical. So let's start with stem cells, the hematopoietic stem cells in the bone marrow that generate all the different types of white blood cells. And of course, the main cell we're going to focus on is the B cells. And the B cells are the cells that make antibodies. Stem cells also make T cells, they make, red blood cells, they make macrophages, they make neutrophils. And of course, for the purpose of this presentation, we're only going to focus on the B cells because that's the way these drugs work. So what do B cells do? Well, they make antibodies, which are proteins that are supposed to fight viruses and bacteria. They bind to the surface of antigens that are present on these pathogens and help the immune system to attack and hopefully clear off the bad guys. And there are different types of antibodies. There's immunoglobin M, which is sort of new antibodies. And I bring this up so that you can read your own laboratory reports and you'll see the significance in just a moment. There's immunoglobin A, which is essentially the antibodies in secretions, such as in your gastrointestinal tract and in your saliva, and in immunoglobin G. Immunoglobin G are long-term antibodies in the blood that persist for a very long time. And it turns out the risk of infections in taking these medications is associated with one, age, other comorbidities, risk of infections in general. For instance, if someone with multiple sclerosis has neurogenic bladder and has a permanent catheter, they're at greater risk of serious urinary tract infections just at baseline, and having low immunoglobins, in particular immunoglobin G. And most labs will read the normal range of immunoglobin G of 700 to 1600. This is milligrams per deciliter. Of course, it's different in different countries, different units, so be careful there. But generally speaking, if immunoglobin G is less than 700, especially less than 500, the risk of infections goes up. So what do these drugs do? Rituximab, Briumvi, Kesimpta, and Ocrevus, they all work in the same way, which is that they bind to this protein, CD20, on the surface of B cells and cause the cells to break open. And generally speaking, all or nearly all of the B lymphocytes break open and die very, very shortly after administration of even small amounts of these drugs, even within hours. There's also another cell surface marker of B lymphocytes, CD19, and there's another drug, Uplinza or inebilizumab, that's used for neuromyelitis optica. So there are many, many drugs that do the same thing, even though they're not exactly the same drug. There's also an intravenous version of Kesimpta, Arzera, that's used to treat leukemia, for instance, certain types of leukemia. Now, these drugs actually have a relatively short half-life. So rituximab has a half-life of around 3 weeks. Ocrevus has a half-life of 4 weeks. Kesimpta has an unusual pharmacology where it has to get absorbed in the subcutaneous tissue, but once it's in the blood, the half-life is fairly short, 2 to 3 weeks. And Briumvi also has a half-life around 3 weeks. And yet we tend to give these drugs every 6 months. Why is that? It's because even though the drug is long gone, which it is after 3 or 4 months, the stem cells take a very long time to regenerate the B cells. So the biological activity of the drug is much, much longer than the actual half-life of the drug. And it varies a lot from person to person. So some people, they could have some amount of B cell repletion within 3 months. And I've had some patients, and I do actually check B lymphocytes and immunoglobin levels in people receiving these drugs. And some people will have 0 detectable B lymphocytes even, say, 2 years after receiving rituximab, particularly if they've been on it for a long time. And it just varies a lot from person to person. There are some factors associated with that. Some people can actually have allergies to the drug and have anti-drug antibodies, and they could get very rapid B cell repletion or even non-depletion, like immediately after receiving the drug, they still have B cells, in which case the drug may be much less effective. But the main factor is probably how long it takes your own body to regenerate them even after the drug is long gone. Now, these B cells, they do a lot of other things. They communicate with other white blood cells. And a lot of people are walking around with multiple sclerosis or other autoimmune diseases, and they take these drugs and they have 0 B cells, but they're not really getting infections. They feel great. I have a lot of patients who tell me, everyone in my household got COVID, but I didn't. I don't even get anything, not even cold sores, not even urinary tract infections, not even superficial fungal infections. Why is that? Well, one is there are other types of white blood cells. The B cells are actually a small proportion of the white blood cells, and they're even a small proportion of the white blood cells within multiple sclerosis lesions. When we do biopsy studies and autopsy studies of people with multiple sclerosis, most of the cells are actually the T cells and parts of the innate immune system, microglia and macrophages, and it was actually a surprise to multiple sclerosis researchers that these drugs would even be effective, and not until rituximab was studied in the early 2000s at the University of California, San Francisco, with studies such as the Olympus trial in primary progressive multiple sclerosis and the Hermes trial in relapsing remitting multiple sclerosis. The drug was successful. It was actually a big surprise to the multiple sclerosis community, and it of course led to the use of all these other drugs, because it turns out the B cells are very important in sort of directing the traffic, initiating the inflammation in multiple sclerosis. But anyway, a lot of people taking these drugs don't get infections. They have other white blood cells, and also these B cells, they can turn into these larger cells called plasma cells. And these plasma cells also make antibodies, and they last for a very long time. They have a very long half-life. And they, importantly, do not have CD20. And so they're essentially immune to the drug. So a lot of people are walking around with no B cells, and plasma cells are a little bit more difficult to measure because there are multiple cluster differentiation or CD markers of them. And so we don't routinely measure them with flow cytometry, but they're definitely there and pumping out immunoglobins, which last for a long time. However, they don't last forever. And so if you're taking these drugs continuously, eventually you run out of plasma cells and immunoglobin levels start going down, and that's definitely associated with more infections. So looking at a clinical trial, like for instance the Hermes trial for rituximab, or looking at the trials for Ocrevus, the Oratorio trial in primary progressive multiple sclerosis, or the Opera trial, which I actually recruited patients into for relapsing remitting multiple sclerosis, or the Asclepios trials for Kesimpta. They show that the drug is very safe with a low risk of infections, but that's not the same as taking it long-term continuously. Now, I'm very concerned about that because of my own experiences as an early adopter of rituximab. I have some patients who have been on it for a very long time, like 2010, 2011, working with my mentor, Dr. Annetta Langer-Gould, who has been using this drug for a very long time, even outside of Kaiser Permanente. And, some people can get infections later on, even if they're stable for many years. And there's this sort of dichotomy where some people believe that we need to give more drug. For instance, there's some evidence that in people getting Ocrevus with a higher body mass index, the drug is less effective because they're effectively receiving less of the drug. And there are actually clinical trials suggesting that maybe we need to give a higher dose so that it's more effective. And maybe the dose necessary to suppress new activity on MRI scans and clinical relapses is not the same as the optimal dose necessary to achieve maximal suppression of disability progression. And maybe we need a higher dose. However, there's a lot of evidence to the contrary. For instance, in Sweden, observational data seems to suggest that people getting 1,000 milligrams of rituximab every 6 months do about as well as people getting 500 milligrams of rituximab every 6 months, roughly speaking. There's also evidence during the COVID-19 pandemic that people who delayed rituximab or delayed Ocrevus because they were afraid of getting severe COVID and taking an immunosuppressant actually did okay on the average. And the viewer may be surprised to hear that because some people do describe a crap gap. They think that they feel worse, that their multiple sclerosis symptoms are more severe when it's been a long time since they've received these drugs, such as rituximab and Ocrevus. And that could make sense, physiologically. Maybe there's some repletion of B lymphocytes. Maybe they're causing some low-level inflammation. Even if there's suppression of MRI activity and relapses, that doesn't necessarily mean there isn't some benefit in treating the subjective symptoms. And I don't have an easy solution to that. I'm just trying to describe the reality. And I have seen some patients who have very low levels of immunoglobins get very serious infections, such as bad COVID-19, despite the fact that they were vaccinated because they probably didn't get a good immune response because they're taking these drugs. And people get urosepsis, severe urinary tract infections with systemic infection, pneumonia, and other infections. And a lot of times people aren't actually checking their immunoglobin levels. Now, checking the B cells isn't necessarily that important because if they're zero, that's okay. That's sort of how the drug works. But having low immunoglobins is a different thing, and in my opinion, carries significant risk. And I do check these, and I think people should be checking these. Now, I'm not giving medical advice. Obviously, talk to your own doctor. There are risks and benefits to taking these types of immunosuppressant medications. And multiple sclerosis is no joke, and people want aggressive treatment, and I understand that. But I'm very concerned when people have low levels, especially extremely low levels of immunoglobulin G, especially if they're older, have other comorbidities and other risk factors. But even young, relatively healthy people can get bad infectious complications. So what I often do is I'll have people take, for instance, rituximab every 6 months for 3 years. After that, maybe I'll give it less often, like once a year, and allow the B cells to come back. My experience is it's still effective, very good at suppressing relapses and new MRI lesions. Now, does that mean that every single person taking the drug does well? No, because these drugs are not 100% effective, and some people do develop progressive multiple sclerosis and have progression even if they're taking these drugs. But that's the reality of the results of the clinical trials anyway. It's not like everyone in the Oratorio trial randomized to Ocrevus had no progression. It just showed a decrease in progression on the average. So we have to be realistic about what these drugs can do and cannot do, and have to weigh that against the risk of the drugs. And I don't necessarily think that it's the best decision to be more and more aggressive without clear evidence, because my sort of assessment of the overall evidence is that it's safe in terms of multiple sclerosis to give less of these drugs less often. So for rituximab, the old dose used for rheumatoid arthritis was 2 grams, 2 doses of 1,000 milligrams, 2 weeks apart, repeated every 6 months, so 2,000 milligrams every 6 months, whereas a lot of people using rituximab for multiple sclerosis give 500 milligrams every 6 months or even once a year with good results. But I'd be interested to know, do you take one of these drugs? What are your experiences? Do you experience the crap gap, the sense that it's less effective if you wait a long time before the next dose? Have you had serious infections while taking these drugs? And have you tried extended dose interval treatment, say taking it once a year, and have you had good results? And do you have suggestions for future videos?